We thank the DRCR investigators and especially Dr. Gross. However, I respectfully disagree on this topic. The ASRS PAT survey respondents overwhelmingly agree with my position, which is PRP monotherapy is preferred over injection monotherapy. The 2-year results of Protocol S showed some unique features of ranibizumab therapy, which is the risk of endophthalmitis, risk of systemic exposure, and greater expense. The 5-year results show that 33% are lost to follow-up. When comparing the two groups, there was no difference in visual acuity, no difference in vision-related quality of life. And the visual field progressed in both groups, which was an unanticipated finding in the ranibizumab group, such that the difference between the two groups diminished over time. The Clarity study looked at aflibercept against PRP, and there were no differences for vitrectomy, contrast sensitivity, or low luminance vision. An editorial on the Clarity showed that adherence to follow-up in the community may be low and could lead to blindness. A real-world study was conducted at Wills. They defined loss to follow-up as greater than 12 months until the return visit, which is not a very strict definition. Despite that, 25% were lost to follow-up. Comparing the two groups, injections did worse on a number of features, all statistically significant. A multi-center case series spearheaded by Mark Johnson showed that treatment interruption in eyes that had been receiving injections were due to illness, non-compliance, and financial issues. When patients returned, they had terrible anatomic outcomes and horrible vision. 46% had hand motion or worse. In patients who are managed with anti-VEGF therapy alone, the unintentional treatment interruptions result, there's that word again, blindness. The risk is equal to probability of an unfavorable outcome times consequences of that outcome. The probability of treatment interruption is substantial, and the consequences are dreadful. Cost shows that PRP is 85 to 90% lower than for injections. The treatment burden is excessive. So medicine is a science, but it is also an art, and every patient is different, and we don't know who is going to be non-compliant. So which would you prefer to do? An almost one-and-done therapy, or repeated injections followed by a period of non-compliance and subsequent rubeosis and blindness? And finally, PRP is highly durable, more cost-effective, and provides better outcomes when patients are lost to follow-up. Thank you.
The floor is now open for a vote.